So we're just going to hear today from Gilles Charles, and he's coordinator for Transitional Mental Health Services for youth at the Children's Hospital in Ontario. I'll just leave it to you, Jill, to dazzle us with your program.
Those are strong words, Lisa.
I know. It's a great program.
It's a pleasure to do this presentation on our Transitional Mental Health Services for Youth program that we've established here about 3 years ago. And so for this purpose, I got a headset because being Francophone, I talk a lot with my hands. But for the auto population audience over there, I'll do my best to put in as many words along with my waving of hands in the air that I'm glad you're not able to see. So, Rena, what I'd like to talk about is I was telling Lisa and Elaine just before this is there's challenges that you always meet, and one of my challenges was trying to put this program together following the research we've done. But the other challenge is putting this presentation to 15 minutes was another one of those. So I hope to be able to present to you and capture a bit of the research that was done, how this came about, a little bit what the program entails, and at the end I will show you a bit of a profile of some of the statistics that we pulled together to give an idea about who is it exactly that are being referred to the transitional program and are they actually appropriate. So this was done through, we've got Growing Up to Do, which was a research that was undertaken by Dr. Simon Davidson, who happens to be our head of psychiatry here at Children's Hospital and the Royal Ottawa Hospital, Dr. Mario Capelli, who is the director of the research, and Melissa Valette, an exceptional individual who put all this together, and I can't say enough about Melissa, how she managed to put all this. And if anybody ever wanted to read this research that was done, all you have to do is Google We've Got Growing Up to Do. And Lisa, if you wish, I could send you by email. I have it on electronic. I could send you the whole article if you wish.
That would be great, Jill. And can we post that article on our Knowledge Exchange Network?
You can.
Excellent.
Though I had nothing to do with that to that point because I knew nothing about it, I'm going to say yes. But I know you could have it on the internet, so it's not a problem whatsoever.
Okay.
So basically, just to state what is the problem, where 70% of the mental health problems here in Canada begin in childhood and adolescence. And I say here in Canada because the statistics Canada, but it's really more of a North American and worldwide issue, where more than 75% of adults with mental illness have their first onset at the age of less than 25. And when we look into the population being served, 15 to 21% of young Canadians have at least one diagnosable mental health disorder. The peak onset of psychiatric diagnosis is between the age of 15 to 24. And through some of the research that was done by Dan Offord and other individuals, only 1 in 6 young Ontarians with a mental health disorder have received services for their condition in the past 6 months. And of course, we all know suicide is the second most common cause of death in our young Canadian youth. So what did our research tell us? Well, in a nutshell, it told us that youth providers struggle to refer to the adult mental health services. And one of their struggles is that they would send many of these youth to a resource hoping that they would meet their needs. And in actual fact, many of the resources that were referred to were not actually appropriate for the youth. Many of youth admitted to have not accessed adult mental health services, and mainly because the wait list was very long. The other reason was because, well, the referral was not properly done, was sent to the wrong place, or they didn't take the referrals the way they would do it. And those who had received services, many of them, and actually when we did our focus group, many of them had actually accessed them through the emergency department. And unfortunately, due to some of their risky behaviors or deteriorating symptoms of their psychiatric problems, had also had to be admitted. Many of the youth's symptoms had seriously deteriorated before accessing any adult mental health services. So what is I'm going to slow my speech because sometimes I speak too quickly and I may end up doing this less than 15 minutes. What is transitioning? Well, transitioning, and this is what we based the whole program about. We developed it around these two statements. It's a purposeful, planned movement from child-centered to adult-oriented healthcare system, and a care that is uninterrupted, coordinated, developmentally appropriate, psychologically sound, and comprehensive. And what those two statements mean, throughout my presentation, I will be focusing a lot on those two statements, which will eventually make sense. And of course, we know that transfer is a termination of care by children's youth providers, which is established with an adult provider. And that's what we're trying to get away from, is making that you're discharged, we're referring you to adult mental health services, but in the meantime, there's really nothing for you. And this is really what one of the major issues were regarding accessing adult mental health services, and of course for youth having deteriorated mental health symptoms. So let's talk about the program. Well, basically the program's primarily goal is to facilitate successful transition of youth 16 to 24 years of age between institutional and community resources. And I will talk more about the community resources in a little while. This is done what we define as our transition team, is a shared management model, meaning we have youth providers and adult providers working together to transition youth to adult mental health services. And this is done through the transition corner, but also through the advisory committee. So basically what happened through when we did this research, I should have mentioned just before, is that there was a big powwow called in Ottawa to address the problem of youth not being able to access adult mental health services in a timely way, or not being able to access them. There were so many barriers. We had called upon all the Ottawa hospitals and the major players, and I will talk to them who they are in a sec, who came together at a table, and not often you will find 8 different institutions, community resources, saying that we need to address this all together. We need to play in the same box to address the issues where youth are not accessing adult mental health services properly. And the ministry was also at the table, and they agreed, and hence how 3 years ago, the ministry agreed very quickly to subsidize this project. At that time, we were calling a pilot project for the first year, and to assess how successful we were in getting these youth adult mental health services. And that's why then it became a program, is because it was a success. What we try to do is every adult mental health services have to submit to me a in-kind clinical contributions. In other words, what is it in their institutions and their community services, mental health services, that they actually have as programs that I could have access to. And I try and see 110, well actually it's between 100 and 110 youth throughout the year, and have them successfully transition to adult mental health services. So who are our program partners? Well, they're the Children's Hospital of Eastern Ontario, of course, the Royal Ottawa Mental Health Centre, which is the youth and the adult programs, the Youth Services Bureau, the Queensway Carleton Hospital, the Canadian Mental Health Association, the Montfort Hospital, who is a Francophone hospital to serve our Francophone population, our Ottawa Hospital. We had our Department of Psychiatry, University of Ottawa involved, and we brought in afterwards the David Smith Youth Treatment Center for Addiction, as we quickly realized many of the youth had many addiction issues that had never been addressed. So as I mentioned before, is each partner will identify specific clinical time, each partner will identify specific clinical time and services that will be available as part of the Transitional Youth Program. So what we try to do is, this is not working out as greatly as we would have liked to. I really have to lobby. I think after I retire from this job, I'm going to become a car salesman, because really, you really need to advocate for your youth. You really need to, when you do a presentation, this was a big thing too, right? When you're looking for adult mental health or any kind of services, I'm not going to specify adults, is the way you present your youth, it has to make sense to the resource who's going to be accepting this youth for services. And this is how we're getting successful transitions, because it does make sense. By the time the presentation is done, not every case is presented, as now as I get to know the different kinds of, or I get to know the key people within each organization, and I get to talk to them so they get to know me. And now as the relationship has been established, so things are running a little bit more smoothly. But this is a humongous part of getting youth access to other services in the area. Access to these services will be facilitated and coordinated by the transition coordinator based on the youth, on the individual needs and strengths of the youth. And this is where I'm talking about that each partner will identify one key person who will be responsible for liaison within their organization about the Transition Youth Program. What's my role? Well, basically the role that I have, is receive all the referrals. All the referrals are sent to me. The more complex ones, and I'll talk to you about the really highly complex ones, I strongly encourage a conversation with me so they can give me some heads up. I complete all the intake and triage team. Look into engaging the youth, the family, and the referring provider into the transitional process. And this is done through me meeting with the youth, and if they agree, I meet with the family also. And having the family involved makes it a whole lot easier because there's information that is shared that sometimes the youth may not recall for whatever reason. And the whole thing makes it a whole lot easier to gather the information that I need to properly get to the right kind of resource. Lisa, tell me if I'm going over time. One of the big things over here is I assess the needs and the strengths of youth to better determine the appropriate adult mental health services. The youth actually enjoy doing this, and we look into what have been your challenges up to now. What kind of services have you had to meet those challenges? What have you learned? What have you not learned? What are the challenges now? I didn't think they were going to be enjoying it this much, but it kind of makes them go a bit of what they've gone through and how they've handled it and what they've learned. So many of them, sometimes it's not a positive experience because they come out saying, I don't know what I've learned. I've had all these services. So this is a bit of a challenge. What is exactly they do understand and don't understand from the services they had in the past? Then I liaise with the shared care partners and coordinate access to the transition team, as this is like such an important part of the whole thing. One of the things, too, that happens with the youth is that many of them are fear going to the adult mental health services. They hear stories about adult mental health services. So one of the things that I make myself available to is for some of the youth with really high anxiety, I will go to their first session with them. And the adult mental health services are quite okay with that. It doesn't happen often, but when it does happen, it's really appreciated by the youth and the family at the same time. I look into not everywhere that they're referred to that everybody needs a report, so I look into what are the most appropriate reports to be sent that the adult mental health services will be benefiting from. To advocate for those who require more urgent transition to adult mental health services because of their complexity and cuteness of their behaviors. I will talk about that on a further slide to show you a little bit how the advisory committee or my adult mental health my partners are collaborating on that. And because this is like a very special service that are being offered to me, and I'll explain that to you in a second. One of the things, too, that we look into is I fill out the GAINS, which is the Global Assessment of Integrated Needs, which tackles the mental health and addiction issues. I don't do the long version if I need the long version, hence why I have the David Smith Center. So I do the very short version. I don't do the short version. Actually, the youth does it. And the OCAN, which is the Ontario Commons Assessment of Needs, which is a ministry-driven questionnaire. And all the youth, it's not compulsory, but most of the youth will fill out those. And it gives us that kind of a profile that we're looking for. It gives us a profile of the youth that are coming in and their needs. I fill out what they called a ANSA, which is an Adult Needs and Strengths Assessment. It's something that was developed by Dr. John Lyon while he was here in our Center of Excellence and Research. And it helps to get the profile that we look for the youth. At that time, also, I do reports for the advisory committee and updates of the program. So this is basically what I do within my role of coordinator of the Transitional Youth Program. So what kind of youth do I see? Well, as previously stated, I see 16 to 24. Most of the youth that I see are between the ages of 17 and 19, and they have to be presently receiving mental health services from one of the 8 involved partners. So as you can well imagine, most of my referrals do come from the Rural Ottawa, the Youth Services Bureau, or CHEO Youth Program. I don't really get many from the adults, though I do have about maybe once or twice a year, and that's because the youth might have gone to their emergency department and they just don't know what to do with them, so they'll give me a call so I can properly direct them. They're in need of assistance to transition from youth mental health services to adult mental health services. They're in need of follow-up due to their complex behaviors associated with their psychiatric diagnosis. They may be in need of specialized assessment to clarify diagnosis and presenting symptoms to facilitate a transition to adult mental health services. Many of the youth, as they gain a maturity and age and development in their age, many of their symptoms take a different kind of a turn. Though maybe the youth provider has been working with this specific working diagnosis, sometimes things change and they get an update one. So I may request a updated specialized assessment from our psychiatric facilities. Presenting with complex profiles such as psychosis, bipolar, severe symptoms in need of transitional services. And they could benefit from another facility program to better meet their needs or her needs. One of the things over here I wanted to specify is through the assessment, some youth at times will discover, you know what, I think I could take a break from services or counseling. As I'm realizing, I learn a lot in my coping strategies, and I just want to put a pause on that for now. They're always given the opportunity to give me back a call at any time that they wish, and I would facilitate a referral for them. It doesn't happen often. I would say maybe 2 to 3 times a year, and it's kind of neat to see them come across. Of course, I like to challenge them when they say those kinds of things just to make sure they're making the right decision, but the door is always open if they wanted to call. And many of them require more than one resource to address their issue. And this is where the community mental health resources that are not involved, not one of our partners, I will refer to them for some of the services. Realize that in Ottawa, for the partners that are involved in, they don't offer family therapy. They don't offer PTSD. So I have to establish these kinds of relationships with these other municipal community mental health resources to be able to offer those services when required. Remember a little while ago I was talking about the complex, I'm almost done, the complex issues that I have that sometimes are very complex in itself. The acuity is really high. I have access to calling a clinical case review from our partners. I will identify certain partners to be part of this, and they will join in. They will make time to make sure that they're part of this discussion, and we make it a little bit like we're doing right now through telehealth, and we will have a discussion. I'll do the presentation, and then they will help me facilitate if it's an urgent entry to their services, if it's looking where else I can go to meet their needs. They will cooperate with me in those regards. And I call them about, right now we're calling them on a monthly basis. We don't always have them on a monthly basis. It's to help them better schedule their time. But whenever I do call upon them, they're 100% in support of helping me access adult mental health services. And to tell you honestly, I wouldn't know what to do sometimes with some of the youth that are coming in that seems like a crisis situation. Being able to access a quick clinical case review and having my partners support the referral and so forth is a relief for me as feeling not having the stress to hold for the youth. So what kind of youth do I see? Well, what I kind of broken it down through the statistics I've been providing and the reports I've been sending, those with one diagnosis represent 9.5% of my population. Two diagnoses is 24%, 3 diagnoses 26%, 4 diagnoses 23%, and 5 or more diagnoses represent 17% of my population. So I think we are capturing the population that's being referred over here because we need to have that kind of a complexity, and I think this shows us that we do. 63.5% are females and 36.5% are males, so we have like 2 to 1 females to the male. The mean age, as I had said before, is 17.66. 18.8% of youth had children's aid involvement. 77% of youth live with parents. 7.7% live on their own. Almost 4% will live with a relative or a friend. And 7.7% live in a shelter or in a home. And almost 4% will be living in a group home. 80% of the youth had a family history of mental illness, where 89% mom had mental illness and 71% father, and the siblings almost 52%. So what kind of percentage regarding diagnosis do we have? Well, the number one, of course, is anxiety disorders, and I'm updating my stats this year, and the anxiety disorders will actually be going up in the 70s. So we're getting a whole lot more referrals with anxiety issues. Mood represents 57. Disorders usually first diagnosed in infancy, childhood, or adolescence is 38. substance-related is 21, schizophrenic 9, personality disorders 9, eating disorders almost 4, somatoform disorders 1.5, and everything else is almost 18%. And that's the question. And maybe you may have some, and maybe we have no time. And thank you for listening.
Oh, that was fantastic. Wow, yeah, because we really, I think we need to give an hour to these presentations. It's really fantastic. It's Mary from BC. I think I just wanted to kind of actually talk more about this tracking that you're doing. It's amazing that you're actually doing, it sounds like, 2 roles. One is you're coordinating and looking at a program, doing program development, as well as clinical practice. And did I hear you right that you see 110 youth a year?
That's correct, Mary. Yeah, that's what I aim for, between 100 and 110.
That is incredible. So can you tell us a little bit more about are you doing tracking, and are you looking at outcome? I mean, across the literature, there's just so little outcome measures for transition.
Actually, we are tracking outcomes right from the beginning. And good question, Mary, because just in April, the ministry gave us some monies where we hired some research assistants, and they went through some of the youth that I've seen that had declined services, in other words, declined even to see me, or they saw me and declined services afterwards. They had another group of youth that successfully transitioned to adult mental health services, and a group where, for whatever reason, they didn't do it, and so they wanted to find out why. And all this is being brought into a report. It should be coming out soon, and looking into what kind of profile of youth do we have that decline services, what kind of profile do we have of youth that access, and those who have decided not to look for mental health services. So when you're looking about outcomes, we have time frames, we have percentage of youth that have access to services, what kind of diagnosis that they have. I'm trying to remember everything else that they put into the report, but yes, we do have outcomes. And it's a very unique, and Mary, it's a very unique thing because, like you said, there are very few information or reports being done regarding outcome measurements for transitioning youth.
That would be really, really great to share once it's available to us.
It's going to be presented to my advisory committee. We're having our advisory committee on June the 13th, and the report's going to be presented to our advisory committee. And what happens afterwards, I could be asking questions about what's going to be happening, but for now it's being kept to the Champlain in our district.
Oh, for sure, it'll be gold.
I think so.
Thanks. I'll pass it to the group. Does anyone else on the call have questions? No?
Well, I do have a question. This is Nancy from the IWK. Just wondering, what do you do when there's also a comorbidity that may be a chronic physical illness? How do you go about with transition with those kids?
Oh, I was hoping nobody would ask me that question.
Sorry.
So because Children's Hospital have a mental health team with a medical component to it. In other words, they have, we call our behavioral neuroscience and consultation team, where they will see children and youth with medical problems that impact their mental health, or mental health that will impact their medical needs. So for those, they're being referred to me, and it's very difficult because then you're talking about multiple departments getting involved into transitioning the youth to adult mental health. So you got the medical, then you got developmental, then you got mental health, and sometimes others that are coming to mind right now. And looking into where can they go get the services, because I cannot refer. One of the things, one of the barriers that I have is not being able to refer to the Ottawa Hospital, and mainly because they don't accept referrals from the outside. You have to go through the emergency department. So getting them to insight for the medical issues, then we could access mental health. So when you're asking that question, it is so time-consuming, laboring efforts. There's so many different departments in other hospitals. Who to call, how to contact them, how to work with your own services over here and outside. It's crazy. So the answer is yes, I successfully transitioned these youth to adult mental health services, and to make sure that they go to one place to also meet their medical needs. But to do it is such a gather of medical staff and everybody else to come on board and do it together in a common front is a challenge. But doable, but a challenge.
So this is Lisa. So imagine a situation where they don't have someone like you to do that. Imagine just the family having to do that on their own. That would be just impossible.
Well, one of our humongous stories was this youth who had medical issues and was being seen for the medical issues, but nobody ever, like within the hospital, referred him to mental health. And he just deteriorated to high-risk behaviors. It was crazy. So all of a sudden we're hospitalizing him and not realizing that his psychiatric problems were not being properly addressed. So those are the kinds of stories we're hearing from the youth when we did our focus groups. So yeah, it's a challenge for me. I would say mission impossible for these families.
Yeah.
Absolutely. Well, thank you so much for your presentation, and thrilled that it's online because that's fantastic. We have your email. Is it because we are a national group, or is it all right that we people contact you directly from their province? Because I know all provinces right now are looking at mental health in transition.
It would be a pleasure, and for sure. I just wanted to say one more thing. Is I was talking to Lisa, and I wanted Dr. Davidson, Simon Davidson, to be part of this presentation. Unfortunately, he loves to be part of this. It's his baby, and he's very driven regarding transition youth services, and he's just stepped down from his head of psychiatry position. He's looking to retirement. But 2 years ago, Simon took a leave of absence to go to the UK and go to Australia to study their transition programs that they had over there. Then came back to Ottawa. We had already started a transition program and looking to how we can put all of them together, have the most effective and efficient transition youth program to address these needs. And I know Simon would be thrilled to present at another time. And I know Lisa was saying that maybe have a longer presentation. He is far a guru in our transition work.
Yeah, I think that
absolutely.
I think CAFC will look to the end of the summer or early fall, try to have that longer presentation as part of our CAFC Presents, and perhaps then they'll be able to share their data as well.